COIN, Community-Oriented Integration Network, is a network of friends, people of experience, who explore how to develop local communities for health, compassionate communities.
I'm the chief exec of PCC. Full name is Primary Care Commissioning Community Interest Company, but we use PCC for short for obvious reasons. We're a not-for-profit organisation. Our focus is very much on primary care and leadership. And we have a offer for neighbourhoods. We do not have any offer, and we don't intend to have any offer on engaging with patients, public communities, etc. So it felt like it would be very beneficial if you were happy for us to have a watching brief on the work you're doing, if we could promote it, and if we could work with you and support you where that is possible to do so going forward. Because
would you be in favour of exploring the ideas that we're putting forward as the future of primary care, not so much the future of general practice, but the future of generalist practice principles in a community setting? Would that be warming to you?
Most definitely. We work across neighbourhoods. We are not general practice centric. We work with all contractor groups. We work with PCNs. We work with systems. We work across the health service. We're doing leadership work with ambulance trusts. We are doing work with PCNs at the moment. So it would sit very nicely if we could work together and we could promote you. We do have a number of publications. We have contracts at the moment with 37 ICBs. So we have some avenues that you may find useful to get some links and communicate your message. And it would be helpful to us because I've been feeling for a little while, until David mentioned you to me, that we have a little bit of a glaring hole not saying anything about communities, how we can better work with them, how systems can work with them to develop neighbourhood health.
No, because what we wanted to do today is to review the two papers that we put in the public domain around what we think, which is more or less carrying the principles of Alma Ata and a traditional generalist practice into a broader frame of health and neighbourhoods. And today is our last opportunity to really discuss these before we have to go more public on them. We don't meet in April, and by then the 10-year plan for the NHS will be probably cemented enough for us to no longer be able to influence it, but react to it.
David was involved with Peckham Work many years ago. Total Participation, Total Health, which was edited by Alex Scott Samuel in Liverpool, and sort of set the tone for bringing the Peckham experiment into the 1990s. I've been the chair of this grand sounding organization called the Pioneer Health Foundation for a few years. And I suppose we've tried, not very successfully, to promote Peckham principles any way we could. But we've been a tiny organization, and I wouldn't say we've been very successful. But I believe that those principles are still very important, and they're not. It's really to do with health. What is health? Peckham experiment asked that question: what is health? And created like a family club in Peckham, inviting families who were within pram pushing distance we're talking about the 1920s. So the centenary of the start of it is next year, 2026. And it really got going from 1935 onwards, because they built a state-of-the-art building with swimming pool, gymnasium, theatre, nursery, all sorts of facilities for these families to use. And they did what they called health overhauls on families. And then starting with the youngest member of the family all the way up to the oldest, and then reported their findings to the family in a family consultation, and then said, look, this is the state of your health. This is what we found. Please use these. We'll, if there are issues that have come up, we'll help you, access healthcare if you need it, but it's completely up to you. We're not going to tell you what to do. So there's a very strong sort of anarchic, anti-authoritarian sort of principle of really not telling people what to do, but to give people an environment really where they can explore what health means to them. And then they would repeat the health overhaul a year later and see how people were getting on. Of course, the war intervened, so it ran for 4 years. Then the war, and then they came back in 1946, but then unfortunately closed in 1950 for complicated reasons, I think, but perhaps mainly because the model, which was neighborhood-based, community-based, not focusing on sickness, much more on health, didn't really fit with the new NHS, 1948 NHS. And of course, funding was very difficult after the war, and so it closed. And the attempts to recreate it in the way it was done haven't really worked. But the principles, some of the things I've talked about, are still really important, and seem to me to be important to what you're trying to do. So to perhaps focus away from general practice, but focus on primary care. And I, like a lot of us here, so-called retired, but I, when I was a GP in a East End area of Sheffield, we set up a community organisation called Dana Wellbeing, trying to model some of what we did on the Peckham experiment. And that organisation has continued to run alongside the primary care centre where it's housed. So we co-located it, and we've tried to Peckhamize the general practice that we're alongside, but not very successfully, because the powers that there are haven't really allowed us to do that.
Helps to remind people that what we're talking about is not new. This is 1978 Alma-Ata. This is what you were doing way back. Peckham experiment was doing, and so on. And it makes sense now, and it makes sense then. But the agenda got hijacked. Now,
yeah, I mean, I suppose just my general observations about what's happening currently, what I think is the best model, etc. I'll just say it out loud. So, I mean, at the moment, I'm busy GP, clinical GP. I do 6 sessions a week, and at the moment, what's happening with all for a multidisciplinary team, but what's happening at the moment is that patients aren't fully being sorted out by a GP in one visit. Patients are being sort of passed around different medical practitioners, saying you better see so and so for this, so and so for this. So there's sort of multiple interactions with primary care, but not really often getting a sort of resolution, and then people go to A&E and end up waiting for hours in A&E. So I mean, I'm in favour of a doctor-heavy model, to be honest. In terms of a GP-heavy model of primary care, in that the GP often just sorts things out face to face, ideally, and knows what isn't important. That's equally as important as what is important. And I think if you don't have the clinical experience, you'll focus on lots of things that an experienced GP will say, oh, don't worry about that, or that's normal, or so on. And you've got to have experience to do that. And that's why people sometimes have come back from multiple episodes of interactions and actually get thoroughly confused in the process. So that's one point. The second point is I really do think it's been a bit disastrous, the wholesale introduction to sort of telephone and digital. I mean, without a sort of impact assessment. There was a survey in Pulse this week saying, patients much prefer face-to-face on the whole, doctors prefer it. And we've underestimated the power and importance of just that visualization of the patient. It's been underestimated, and we've been told by colleagues that, oh, you don't need to see the patient anymore, we can do it all digitally, and so I just think that's complete rubbish, and the patients know it's rubbish as well, which is why they go to A&E to see a doctor. The patients have got common sense and know that you actually need to see the patient in person for a lot of things. So I do think my view is a doctor-heavy model, default face-to-face, default. Of course, there's got to be email and telephone, but I would say default should be face-to-face. Because again, on the phone, I spend loads of people saying, oh, you sound unwell, you better come in. And then I'm a secretary or a reception person trying to fit them in for an appointment, which seems to be a complete waste of time because, you'll spend half your time trying to arrange someone to come in for a time that suits them.
Before today's meeting is over, let's explore that old idea of we needing the most experienced people at the most peripheral points in order to make sense of the complexity rather than identify specific triage things according to a linear medical model before today's meeting is over. And the other is how we may be able to enable continuity of care. In certain instances, that includes IT. So, for example, you can develop trusted relationships face to face and then follow up with phones. But you can't do it all one way or the other.
Yes, it's following on from what David was saying is how to do that work within the newly described newly described environment of how our work fits into the model of neighbourhoods generally, and what on earth is a neighbourhood going to be. I agree to a point about not just doctors but clinicians. If we're going to design or help the design, then clinicians don't usually like living, and the difficulty is living with the results of other people's thinking. And when I say other people, non-clinical thinking. So how do we bring in a clinical viewpoint to the creation of whatever neighbourhoods are going to be? And that's what I've been hopefully describing through the programme that we've got now into its fourth year, the Complete Care Community Programme. Because what we're trying to do there is give the power of context rather than just talk about policy. So we've got abundant case studies which are demonstrating a team-based approach to complex lives, complex care, the thing that the NHS doesn't do very well. And my concern is that the focus will yet again, even on this left shift, will be to how the community helps the demand in hospitals, as opposed to how do we create a more vibrant extended care service that is community-based rather than hospital-based. And there's some big ticket issues that go along with that, which been harping on for a long time, because if we're going to have influence on what a neighbourhood might be, what its clear purpose is, the reasoning for their creation and the aims they will serve, I think it's the collective knowledge that we've got on screen tonight that might help inform that. Because at the moment, everyone's using the terminology, everyone's saying neighbourhoods of the future, and no one has told me in any form what they might look like.
What is the role of public health in this, and what should we be saying now in public health while we've got the ears of some senior people? And secondly, social care. What might be the ways in which we would propose that social care could fit in with what we're saying? I would suspect that one reason why we're not hearing much about what a neighbourhood is that people just don't know.
But that means you can fill the space.
Yes,
because it's feeling a bit like an assault here in the US right now. So as a primary care clinician who's taken care of people in underserved settings for many years, the conversation we're having about prevention and neighborhoods and community, all of it makes sense, but our entire system is literally breaking down overnight in a way that has been hard for those of us, both academics and clinicians, to understand. So yesterday, the headline was Trump team revokes $11 billion in funding for addiction mental health care. They've been shutting down the Veterans Affairs. They're talking about shuttering completely the National Institutes of Health. I'm teaching population health to undergraduates, and the data is no longer accessible. The data went dark. Our articles, if it uses any of 48 words, including the word socioeconomic, or diverse, or women, or pregnant, it's literally being erased. You can't find it in the internet. So I'm getting news from universities across the country that they can't find their own data, they can't access national data, they can't find articles they've published because the repositories have gone dark. And what we know is that they can't balance the budget that they've talked about without completely cutting Medicare and Medicaid, which are our funding streams for the vast majority of our elderly and certainly our people of need. And so from a funding and policy point of view, I think we can't just talk about communities. We have to talk about public health. We have to talk about the finances. We have to talk about the policy. So when I see the headlines this week that NHS England will be abolished and 9,000 administrators will be taken out of the system, we train doctors based on federal funds. The university hospitals will not get doctors. The funding for science has literally been cut overnight, and many universities have completely canceled their PhD programs. Our ability to function next year with data science trainees and understanding of the ecosystem that is healthcare is already severely hampered, and we won't see the effect of that overnight, but it is creating a panic. We are meeting with our chancellor every week, and they're telling us that we'll run out of funds as an academic university, one of the largest public universities in the country. We could run out of funds in 6 months as a university because all of those programs all connect. There's a prediction that 15% of rural hospitals could close within 6 months in the United States because that funding comes through federal grants. And so, I could go on with all of the kind of horror that we're experiencing on a daily basis, but the idea that neighborhoods and community, in my experience as a clinician, has always felt like a cottage industry. Like, I know my patient, I know my community, and I want to be able to have that relationship. Absolutely. But we live in an interconnected world of an ecosystem, and all of those grants have knock-on effects of how, the federal grant gives money into this program and that funds research, which then feeds a trainee's ability to do both science and become a clinician. It's all connected. So as you start severing those pieces, the ecosystem falls apart.
And it feels like every day in the Danish news, we get another quote of something historic in a bad way that comes up. And really the tension is rather high. You can't go anywhere without talking about the latest comments that have been made towards Greenland from Trump's side. And even though that Denmark and Greenland is not essentially the same country, you can't help but fear that someone who's been such a close ally, who's such a big country, is suddenly turning towards you and saying, I'm going to take it, whether you like it or not. I mean, it is essentially fear, and our prime ministers, in my opinion, has been handling it very well, trying to comment very politically correct on that America used to be a really strong ally of ours, and we feel rather under attack, not just on our own behalf, but on behalf of the people of Greenland, really.
Because clearly we're in very dangerous times where this controlling, linear, divisive, combative approach to change ideology seems to be winning in many places.
Several things, really. First of all, when Jack was talking about the Peckham approach, one of the sadnesses of Labour introducing the NHS is that Labour has been bedeviled forever with statist thinking, a sort of top-down model. And nationalisation often did that. It was mainly about the provider and about some central top-down control, and that has dominated NHS management as well. And when Jack's talking about that more organic, rebellious, or whatever adjectives you were using, Jack, neighbourhoods could possibly release that if there's enough people to say what we're going to do now rather than just be whinging. The model of Peckham didn't fit well with that top-down nationalised model of the health service, which is a pity, and that general practice has been often relegated to a sort of hands-on local sort of thingy, which was never had any much influence on the policy of the NHS. So that's number one. Can we recapture that? And are we strong enough to map out ways of thinking, which some of us did in previous reforms, like fund holding and all the others, that even though the policy was directing one way, we often hijacked it to do what we wanted, but use the opportunities. But is that an approach? That's number one. So there is hope, but it means there's some pretty heavy lifting for all of us who think in the ways that Coyne and others do. That's number one. On David's point about Dr. Heavy, and I suppose just an adjunct, you could have a non-doctor, but would have to fit the same role, because the NHS primary care has been built on a relational model, and it's becoming more and more impersonal. So when I hear GPs describing what they're planning to do, it sounds like a hybrid between an urgent care centre and an outpatient department, rather than that personal care that has given general practice its rich heritage. So there is an important thing that, and it may not have to be just doctors, David, but they're often the ones that actually have the broadest training and knowledge. And there are nurse-led models, as Paul has often quoted, but it's a continuity and relational element that we have to maintain. And I'm worried is that general practice is becoming depersonalised in England, UK, that whenever we have reform, which is desperately needed, it tends to be a structural reform, but mindsets stay the same, and it's just a lot of shuffling around of boundaries and organisations. How can we fill that space? And what we're trying to do, Paul, by swanning around with all these people like at the department and general practice, is to try and get a coalition. I won't say coalition of the willing, that has other connotations at the moment, but a coalition of people with similar views, even if not identical, to have some impact on both setting the policy and what we do after the policy. That's just as important. And I think that's where we need to be. Just taking a comment on Laura's point, NHS England, I actually support its demise. I know these are job losses that's a personal thing, but NHS England is a hugely duplicative organisation, which the Department of Health was doing beforehand. Now we have the Department of Health and NHS England. So we've actually got too top heavy. It's not the destruction of the health service in this particular, it's just getting rid of a duplicative bureaucracy, and hopefully we can release some of those resources into health service delivery and care. General thrust to a different model of primary care being centric in the health service. And part of that is about the public being an integral part of that rather than being a provider-driven thing. So I think there is hope, but at the moment it's got to be action that as we go around, everybody's got to, at every level, trying to say that this is an opportunity to grasp what we've already wanted, which is a personal a relational based primary care, and that the patient, public, whoever, needs to have a continuity for most of that time. Otherwise, it's just an impersonal service. We have to capture the best of that and get the new policy to go in that direction. There's a coalition building, which is what I was saying to people like the NAPC and the college, that we need to be thinking of this, some of which may well have to be in communications, joint communication, but the work that we're doing in national contacts has to be mimicked at local levels as well, because there's a tendency in the health service to think once you've got the policy, everything's done. No, it isn't. It's done at the beginning. So these type of meetings have to be done at local primary care network levels, which I'd like to have some stories.
Thanks, Paul. I listened with a sort of mixture of concern and actually pleasure when I heard about some people being attuned to the way that we think and what we've been trying to do. I mean, on the concern side, I think it comes back to what we've talked about previously, the challenge of making the case both for the COIN approach and for public health. And I put a quote in the chat from a fairly senior person within the NHS. Yeah. So much of making that case is about making the economic case. And I think we can and should be making the economic case, certainly public health, and also I think the COIN approach are actually good value for money, as well as making sense in terms of being in the interest of well-being and health. On this issue of the science, I mean, I know that the whole thing about community development goes back many, many decades. I don't know whether that's what people would call science, but I have been reading again recently about social capital, which I think links closely with community development and with the COIN approach. And there is a sort of science behind that. And there is evidence that social capital, as well as, improving well-being, does make economic sense as well.
Building trusting relationships, the program on our reviews of the 65 what we're calling demonstrator sites, which are anchored in primary care networks, but quite quickly realized they had to have relationships with council services, third sector, and strong relationships with groups of people who were identified as being underserved, marginalized, vulnerable. And the first report, we actually found that we categorized the 4 T's of what were making these demonstrator sites functional, and building trusting relationships between both the recipient and provider of care at an individual level, especially when people had had bad experience or had been excluded or marginalized, and then trust in new provider teams who were delivering care to people who needed something different than traditional NHS delivery. The other thing we found was that we often talk about transparency, but there was a lot of mistrust in the organizations, and there was a sense of what is the extent to which an organization allows the recipients of care to understand and monitor its operations, because just giving people a service that they didn't understand, had no ability to shape, and had no information from them, led to poor care. The other thing about building relationships or new services, the third T was surprise time. And we have 2 tighter schedules or annual cycles, certainly in the NHS, to try and deliver or fund programs. But what we're finding into the 4th year now, some of the design of projects and some of the learning even to understand the nature of the disability, the extent of the disability, and deliver care, some are still struggling into year 4. Now, will we have that time to build the relationships, build the new connections that if the NHS is going to be successful in, for example, reducing health inequalities? And then the final bit was the final T was training, both at undergraduate and postgraduate level, particularly within non-clinical competencies. And as you were saying earlier, building the science of team-based care, team development. There's a lot of science behind it. The science of scale, how to scale projects from individual, interesting approaches to larger scale delivery across larger footprints. For example, from a single practice to whatever a neighbourhood's going to be. So they were the 4 early themes around building teams, building new therapeutic approaches through the relationships that needed to be developed, particularly in people who had previously bad experience or no experience of care at all.
I mean, do you think some of your 65 primary care networks would willingly promote their stories of how they've been successful in developing trusted relationships?
Yes, and I also found that clinical colleagues are far more impressed by, as I was saying earlier, the power of context than the power of policy. So where it's being delivered rather than saying what should happen, people saying this is how we've done it. NHS England have always been interested. I've never seen a policy, I've never seen a piece of research actually being delivered. You know, there may be a huge trial, but then somebody always gives the case study that proves what's going on, and that case study is a story. So all the sites are delighted to have platforms to talk about how they've designed, developed, and delivered services to inclusion groups, marginalized groups, people who have been underserved.
And might they be able to, my thesis is that shouting loud about this from all over the place in the next couple of months could have an effect on the media, the policy, in a way that simply continuing the argument from a one direction, particularly medical perspective, wouldn't have. Do you think some of your case study sites would be happy to sort of start making noises about this in the next couple of months?
Sure, they would, especially the ones that have started on ways of delivering service that I would never have thought of. In Cumbria, they found that the biggest impact in where they've got a very high degree of pre-diabetes, so like 7 to 8% in this particular community, the way they've reduced the conversion of pre-diabetes to diabetes is move the bus stops. I want to have got one. Vaccination uptake in Somerset of where there was less than 5% uptake of MMR or measles vaccinations. They found that doing a vaccination program in the local swimming baths changed it to nearly 90%. I wouldn't have got that as a pop-up service. You know, we think we know where people will turn up. It's going to be the general practice or the community clinic or the hospital or somewhere, until you actually talk to the people who are receiving the service. Then, so I know there's lots of stories about things that have either the place of care, the way to register people, because often registration doesn't work for people who are have had poor access to care. So I think telling stories of things that we haven't heard before.
And James, how much of this do you think is cleverly thinking where the bus stop should be, and how much is actually listening to people on the ground who say, the bus stop is not where it needs to be?
What is determining why people weren't going for care? That was an example of particular post-COVID. If in a rural area with high poverty, who didn't have transport, but the only service was either at the local clinic or the local hospital 20 miles away, people just didn't go. So the first time they turned up was when they rang 999 because they had a black toe, as opposed to finding a different way of transferring people to the place of care, not necessarily the place of care changing, but that was a discussion with the local council to see if the bus routes could be changed.
But I've been thinking quite a lot about top-down management, and David, your comments I was very interested in, and as well as the importance of relational general practice as opposed to functional general practice, primary care. A couple of months ago, I was presenting to the Health and Wellbeing Board of Brent Council. This is over I'm leading a move to get Brent to sign up to be an age-friendly borough. There are times when you need top-down leadership, but then they've got to get out of the way and delegate downwards. And
I mean, most of these managers aren't bastards, but their framework of thinking is so different.
Yeah.
And unfortunately, when clinicians, both doctors and others, get into these quasi-management positions, their mindset is actually that whether it attracts them to join these things or whether they get crushed by the surroundings, they become the same, and they don't trust anybody. And that it's an issue of trust for a lot of these. It's rare because the best managers I've ever known keep control because they have to have some sort of control by letting go. That is such a rare attribute. But I find our own profession are some of the worst when they get into these positions, and I don't know what we do.
I was just going to comment on the role of the management consultancies as well. That I think the hundreds of millions have been spent to all the big ones, McKinsey's and PWR, KPMG, and they've actually given KPMG, you come up with the plans, and these are KPMG have many qualities, I'm sure, but I don't think many of them have seen lots of clinics of patients, so they come up with all these unrealistic plans that are very transactional, and they miss. It's all very much to do with metrics and numbers and. What's it? The McNamara fallacy, where it's all to do with numbers and so on. But you miss out on that. If the patient doesn't trust you, no matter what the numbers are, they'll go to A&E or see someone else. So, and for me, trust. It's very difficult to get. Trust is absolutely essential, because if someone doesn't trust you, they're not going to, probably follow your advice. And it's very difficult to get trust without actually looking someone in the eye. I think looking someone in the eye, saying I trust you. Is so powerful, and the management consultants, that doesn't really factor, I don't think.
I want to just tease out a little bit about looking people in the eye, because I know that people can look you in the eye and actually destroy you at the same time. So there may be some way of looking in your eye that actually is better than other ways. Laura.
Well, I certainly don't have any answers. I've quickly pulled up the article that Sanjay posted around social capital, and there's a nice chart in there talking about trust, social capital, and boosting economic strengths. And so we can study these things, like how trust can boost certain things. And is some of my research there in the UK was a part of the IHI and quality improvement world. And so, we were really trying to get managers to think about all these things. And now I'm teaching nurses management before they graduate with their bachelor's. And they're so busy trying to learn how to measure stuff that it's getting harder to understand the patient care part, because we almost take it for granted. And so maybe in some way I struggle to agree with, but kind of need to agree with David's thought that maybe there's too many duplicative efforts. We're busy finding things we can measure and then measuring them and then measuring everybody else's measurements, and then we've lost the plot. But somewhere in there, I still am convinced, as I always am on these coin meetings, that we can actually put trust on a scale and patient care on a scale, and the sense of relationship that you have with both your patients and your community, that creates and continues to contribute to better care, it's just not going to be a beautiful, it's not just going to be in stories, but it's also not going to be in just a simple chart where the numbers go up and down in a simple way. That we have to
let's dig into this trust thing a little bit, because I know a couple of people who I can absolutely trust to undermine and lie and harm out of a kind of compulsion. And I just wonder whether we're hiding behind the word trust when we mean something actually a little bit more than simple trust.
Seeing each other in the eye sort of topic. It was more really a question about policy, because as of quite recently, it's become mandatory for all the GP clinics in Denmark to offer video consultations. And especially when it was made mandatory, it has been available for a while in some clinics. There's a lot of different opinions from clinicians mostly, but what I've read and seen in the media from the patient's perspective is that it's actually been received rather positively. That they now feel like they have better access to their doctor via their cell phone while they're at work. Essentially, not just like e-messages that they then have to wait 5 days, but they can actually book an e-consultation and see the patient face to face, but over an e-meeting. So I was just wondering if that's policy in England as well, or if it's more of a choice.
I suppose in my book, trust is, built over time. So people have to, you have to have a relationship with people. We've talked about these key words, continuity of care, relationships, and that's how you build trust. So there may be people, Paul, who you think are untrustworthy, but you've not got a relationship with. You know quite quickly if they're lying or they're. Well, that's my view anyway. Trust is a good word. I think we should try and promote it. And I suppose, having retired as a GP and been more involved with the community organisation that we set up, that as I said earlier, works sort of alongside the practice. So the people there, you could call it social prescribing, I suppose. The sort of link workers, but we provide that. Our organisation provides the people that other practices or PCNs employ as link workers. And the people we have been going, 10, 15, 20 years. They know their community. They know the people that they're dealing with. They run groups around chronic pain, diabetes, all those sorts of things. But so they're not run by the doctors or even by the clinicians in the practice. They're sort of separate, but trying to integrate together and work together. Because I think there's lots of interesting things going on in Sheffield. So there's an organisation called Citizen Network, which has done a load of work around neighbourhoods, not specifically to do with primary care, but just about identifying what neighbourhoods in Sheffield are, what they might look like, how they might relate to local authorities, the mayor's office, and work with Hallam University in a sort of part of Hallam University which is located near to where the Darnall Wellbeing Group are. So there's lots of sort of collaboration going on lots of levels, including with primary care, but actually much wider in a sense, which I think needs to happen to build healthy neighbourhoods.
It was Craig Bishop, who isn't here today, said we should be influencing things not over here, which he was talking about the politics, but over here through the media. And he was pointing to the film directors that we had at that meeting. We also heard from Peckham Experiment that this is not new, but it seems to be very difficult to describe and implement, partly because it isn't dramatic. You can't actually count somebody who hasn't had a heart attack. Blue zones comes to my mind, but that hasn't been mentioned today. But I think there is some evidence from blue zones that social awareness and social capital and building social relationships does significantly impact on the health of everybody. We've talked about fear in various places, but also inside very dramatic and dangerous moments, there are opportunities that we must take advantage of. We need to get stories out and all shout at the same sort of time. Trust builds over time, and by trust we don't just mean predictability, but somehow a trust that people will care. That somehow that we're trusting them to do the right thing by us, to reciprocate in our sort of the better parts of ourselves. Groups run by people who are not doctors. And how do we arrive at that situation where the two are entwined? David Mummery's ideas of the Dr. Heavy or Dr. Dominant, the most skilled people being at the most peripheral point, perhaps, and also supporting the development of loads and loads of groups that are moving issues forward. And then the last word I got here is social capital.
The only thought that I would add was just picking up there's a sort of thread tonight, I think, which goes through quite a few people, and which isn't kind of maybe fully in the papers, perhaps. Sanjay kicked it off with the social capital idea. That social capital, what is social capital anyway, and is it an amalgam of things, but going back to the individuals? And that picks up really David Morris's work with the Centre for Citizenship in the Community, where they did a lot of work down on the ground, research, using people locally to work out what they wanted. And that reflected Julian Abel's point, I think, to coin a week or two ago, that it needs to start with people on the ground, rather than us kind of in the papers just sort of setting out certain ways in which we might start. And very interestingly, I think Jack picked up the same kind of points around social prescribing, which is getting a bit more sort of lower down, with those interesting people that know what people need, whereas back down to that level. And there are other things like personal payments. And then really just to throw in, where do the health and wellbeing boards sort of come into this, which have been around for ages, a bit like that whole comment that we've had a lot of this stuff around for many years, but why are not health and wellbeing boards, which I think are still around, and ICPs, which are the amalgam of, local authority and health, you just don't seem to see much of that. So, can we bring that in?
The issue that has been the disconnect in any reform ever since 1997 is the disconnect between clinical and fiscal decision making. Where are we if we wanted to, particularly in neighbourhoods, have a responsibility or even accountability for stewardship of resources? It's the he or she who pays the piper calls the tune. And one of the failures of reforms to be sustained, in my opinion, in the past, is that we always rightly start with changing care pathways, how care is delivered. All the international evidence is, if that's going to be sustainable, you've got to change payment systems. And that's the thing we never do. And if you change payment systems, then institutions change. So if we're going to have the left shift from hospital to the community, what happens to the hospital structure? Because the evidence is that if you leave all the structures exactly the same and the payment systems do not change, then you will never have sustainable reform in fund holding, and then multi-funds total purchasing. We started to have clinicians who were in charge or stewarding, or indeed deciding on that good old make or buy decision, and made more, bought less. And we started to see some reconfiguration of the institutions as a result. Since that time, since 97, the institutions have stayed exactly the same. And indeed, we have the rhetoric of more community-based services, but keep investing in hospitals. And this is not a sector war. This is just a case of, I don't believe we'll have sustainable reform unless the people who are prescribing, referring, making decisions with people, people who become patients, if they don't have some stewardship of the resources, if it's always external, And I think I would agree, there's an opportunity now that NHS England, it's interesting, NHS England, it was never called NHS England, it was the commissioning board. It was just people on the commissioning board didn't like the name, so they wanted to change it. It sounded better to be the Director General of NHS England rather than Director General of the commissioning board. But that's what it was. But then it was about a commissioning board determining how money was spent. And that was completely detached from the people who were delivering the care. So where are we on sort of having a debate about reconnecting in neighbourhoods, even to the extent of having whole population budgets linked to a neighbourhood, and the teams that are doing the work have some say, if not control, over budgetary decisions. There's still going to be a process of how that's allocated, but if we don't change the allocative value and how we then utilise services, we'll always have nice discussions about changing care pathways, but we won't ever have it sustainable because we won't have payment reform. We don't reinvent the wheel now, we just reinvent the flat tyre.
Do you think it's possible to devolve budgets to neighbourhoods in a way that they learn from other neighbourhoods, such that they can gently, friendly challenge and understand and learn? Because one of the problems, it strikes me, with located to another entity is that entity then redevelops, top-down controlling conflictual stuff, because they actually don't know how to go about something different. And if you embed some kind of learning process between them, possible?
Yeah, I would. People think, oh, there's just going to be cash shifted, as opposed to, no, it's an incremental process. It'll be a learning process, and in the early stages, it'll be indicative. But it's a case of saying, at some stage in the future, there will be a whole population budget managed by the entity, which at the moment is going to be called a neighbourhood. But yes, that's not going to be a process that you just turn the dial overnight. It will be incremental and start indicatively, but that will build in then experience and learning as a result of that.
When my wife was sick, we saved an enormous amount of hospital costs by caring for her at home. But the cost to the community agencies, of which there were, I think, 5 different, so schools as well as GPs and palliative care nurses and social workers and everybody else, none of whom actually were communicating with each other. The cost to them each was considerable, but the overall cost savings were enormous, but no way to tease out the complexity of that.
But it'd have been a notional saving, not a real saving. When we talk about moving care into a community and then caring pathway, we often talk about, and this saves hundreds of thousands of pounds.
It doesn't save
because it just reduces the weight. Sorry, David. Yeah.
But if the budget was allocated to an area which then also had to explain why it was using that and learn from other places, that may be possibly overcome.
Because I introduced this evil thing about money by talking about fund holding. Fund holding was a Tory policy, and I was really keen to do it. And it wasn't because of what they wanted us to do, which was purchase and all sorts of weird things. I wanted a budget. And because when we talk about trust, one of the other things that human beings need is some locus of control. And one of that is one manifestation of it is to have some devolvement and responsibility. Some won't like this, others will. But you don't need to give loads of money, actually, Paul, because nobody will trust that suddenly to change all where the money is. But small amounts can often begin to do that learning process where you're given bits of cash to have some responsibility. In tight times like we have now, there's even less of a fertile ground for having that radical shift. But it is about locus of control and having, because otherwise you just do what you're told from the top. And I won't bore you too much, I had this interesting discussion when we were going to get budgets. And the local finance manager said, well, I don't want you people to get budget because you might overspend it. And I remember saying to him, well, you don't know if I'm overspending it now. It's a false thing that they do. And that's a lack of trust rather than actually being an effective use of budgets. And so we don't have, I remember Blair was, when he had his various organizations working to him, were trying to explore about giving budgets to some local communities. It never got off the ground because other pressures come in. But we do need to shift means of accountability as well as talking about it. Otherwise, as James says, nothing will ever happen. So there is an issue. In all the writings I've done about a new primary care and doing more, implicit in all this and explicit in some of my writing and in things like the NAPC, is that there should be some budgetary responsibility. Otherwise, you can't have the levers to change things. Whether you can do that to amorphous commitment, I don't know. But there have been experiments. I remember in India, when they gave poor people some budgets about education of their kids, the standard of education improved because they had put more pressure, they had leverage instead of having to just put up with what you're given. And there's some really interesting behavioural empowerment changes that we need to explore too. We'll have to do it gradually and in small bits because it's not the right time, is it, when we're talking about everybody being broke? But we have to think about enabling people by giving them some more power and influence. And that's a real issue about shifting.
I just want to support what David's just said. A universal basic income, every citizen should have that, and it would give them control. And there's a whole movement around this, very, very strong in Sheffield, and worldwide, really. And Manchester are going to pilot it. The mayor there, Andy Burnham. So it just follows on what David has said about giving people more control, because when they have control about their lives much more, all sorts of things flower. And if you can get those people to flower, then your community and your neighbourhood will flower, and people will become healthier, regardless of what the healthcare is like. That's important. We've talked about that. But those things, and that just follows on from, I think, what I learned from the Peckham stuff. But universal basic income, I'm just throwing it in.
But I wonder if we want to explore, I wouldn't mind, Ian, if we do have a meeting, whether James could produce one of his PCNs to give a chat. I'd like to get some of the detailed organic stuff that goes on rather than just a headline report. And if you had to say somebody from Jack's, whatever, it would be nice to just hear people from a bottom-up approach talking.
What I've heard is, and what I think the action points here is, we're going to email all, and in a moment I'm going to go around and ask everyone for their final comments. Email all COIN members to tell them what we're doing, reminding them of this meeting on the new meeting on the Thursday, the 24th of April, and that they've got to get their submissions in before the 14th of April to the government for NHS stuff. We want everyone to shout at the same time in the next month or two, especially next month before Easter, when just the importance of trusted relationships that requires being built over time, and people from different backgrounds working together. And that's an always and everywhere things. The more impersonal it becomes, the more things fragment and worsen. Something about the understanding how you actually do this. How do you build compassionate communities, trusted relationships? That's a piece, you know it when you see it. Lots of people are talented, especially in healthcare, to do it. But what are they actually doing? And some of this is pretty simple. You look at the patient rather than the computer screen, for example. You know the name of the person and read their notes before they come in. Some very basic stuff like that. But then more advanced things like actually caring.
I'm going to throw in family. So when I was a GP, I explored. This was partly Peckham, because Peckham thought the family were the unit of health, not the individual. But I got into a thing called thinking families. So with other GPs and therapists, we did some family work, and basically knowing families, not just individuals, because you just mentioned, Paul, knowing your patient, but knowing your patient in their context, which often is their family, their extended family, and understanding all sorts of issues. And basically communities are made up of families who then get to know each other. So I'm just going to throw that in.
Jack, what do you make of the suggestion we made that around the home where there is a carer, we develop, or society develops, team-based family or household oriented care, and that the place where social services and faith traditions and schools and GPs work together.
Yeah, absolutely. Families don't have to be blood necessarily. They can be, relational practice.
I feel that general practice need to sort of unify, because at the moment it's quite, disintegrated. There's sort of partners, salaried, locums. You probably heard there's lots of GPs who can't get enough work. So the way the financial system, I totally agree, the finance will dominate how things are delivered, but the practices don't have the money to actually employ doctors. I mean, people aren't employing salaried doctors because of the funding mechanism at the moment. So really, to somehow get the doctors unified as a group, as GPs, and my view is that you pay the doctors in accordance with the amount of clinical work that you do. And at the moment, that is not the case. So you can be a GP partner, work one session a week, spend the rest of the time in lots of meetings and still earn the same, and that you have to link the payment to the amount of clinical work done somehow.
And David, what about the notion of expanding the role of general practice to become leaders of collaborative locality-based health and healthcare?
Oh, definitely, yeah.
So the principles get applied much broader and get trained in understanding how to do that.
Yeah, and make it and try and create flat hierarchies, because I mean every organisation has its own culture, but some GP partnerships are still quite hierarchical. You have sort of boards and so on. That flat hierarchies where everyone is collaborative tend to work better. And I think we can learn a lot from Denmark, from Kath, I think, because they seem to have got a lot of things right. So.
If you want to tell stories at our April meeting, I would suggest we email or even invite Hazel Stuteley. I don't think I've ever heard a better story told than the one she described when she gave a presentation to us. The second thing is, you may have noticed there's been an increase in funding recently announced for the arts. The arts are in the ascendant, and we've covered the arts so often. And I think making a bit of a push on that and inviting some of the people who've talked to us about their work in the arts would be a very good idea.
I'll be really keen to hear the stories. And I think we've identified few individuals. I think this will sort of bring those papers, hopefully, or just the concept a bit more.
And can you
that it's easier to visualize or just, share that with others.
It'd be nice to influence policy, but it's really important to influence policy development, because that's often where good policy becomes rubbish policy. So some of this stuff are gathering stories. It means that we need to have an ongoing communication in some way. And that's how we need to also see if the college and people at the NAPC would be willing to do that. We need to continually keep putting pressure, because policy development is really rubbish often. Often you get quite reasonable policy commitments and then nothing happens. So it isn't all our eggs in one basket to influence actual policy words.
I've just found it really interesting this evening, and in particular thinking about the locus of control is, the need for trust, how to get that continuity of care, how signposting and the opportunity to build on the strength of communities fits in. And I've obviously read the papers behind this, and we would be very happy to support and promote what you're doing and communicate out. But
I'm really thinking over some of what James talked about in funding, and that we use words that say collaborative care and community, and then we fund hospitals. And so I want to think for a minute, and this is my bias as a nurse in primary care and having taught nurses in primary care in the UK, the model of training clinicians and both doctors and nurses and paying for their training in the UK.
we don't train generalist nurses, and we don't have a university model of primary care nurses necessarily. And so we keep turning out hospital nurses, and yet nurses are the largest portion of the staff in the NHS system. So can we think differently about how we fund training so that training is actually taking advantage of what we really think is community and population health and public health, because the largest staff set in the system isn't actually getting that training or paid to deliver that kind of care, and they all return homes to their communities. The nurses particularly are also caregivers, are also parents, are also community members, and we're missing the beat to train them to work all of that into their practice if we only think that they're bedside care in hospital.
Stories and policy development. I don't know how you put it together. I recognise the importance of telling stories, but to give flesh to the dry bones of theory, I suppose, is how I approach it. Policy development. I take your point, David, that there's a disconnect there, and it's in my head as much as anywhere else. And so I'd be interested to follow this one up. Just to say to Laura before we finish, you must be having a really terrible time, and solidarity.
Thank you.
From the demonstrator sites, but I think it is important at this stage, whilst I agree with policy development, we know that the policy is being set. I think it's probably better to have 2 or 3 high impact issues that align with current policy rather than trying to drive a new way of working. So I'll see if I can get stories that will align with what I think is happening with the neighbourhoods. And if we did have a debate about devolving or delegating budgets, how some people are managing that. The only thing about when David Munro was saying about consensus from GPs, there's always that turnaround of, getting GPs to work together is like herding cats. The answer to that is then, well, where you put the milk, it's dead easy to herd cats. If you put, if you got the milk and put it in the right place, then you can get consensus. It's just whether we can have points that links to that analogy.
But like the one theme that really sort of resonated with me throughout this talk, through hearing David Mumry's troubles with patients being, sent in and out, and hearing you, Paul, talk about how there was no communication in the care for your wife and all that, was really collaboration to me, like the collaboration between the different disciplines revolving around patient care, collaboration within the clinics, collaboration within sort of how we are able to make the system talk together. But how I can find a story in that, I have no clue. But that was sort of really what I gained could really improve a lot of these things, really, if we could somehow make a unified communication with one another.